Good afternoon, ladies and gentlemen. My name is Jang from Bucheon Sejong General Hospital. Today, my topic is how to optimize functional results of PCI in daily practice. First, let me review the evidences of currently known benefits and harms of PCI in stable coronary artery disease. This is COURAGE trial, which was published in 2007. Patients with stable coronary artery disease having significant stenosis and proven myocardial ischemia were randomized into either PCI group or medical therapy alone group. PCI as an initial management strategy failed to further reduce the risk of MACE, survival, ACS, or MI when it is added to the optimal medical therapy. And there is the recent ischemia trial in 2020. Ischemia trial and the previous COURAGE trial are very similar in that they involve patients with stable coronary artery disease with proven myocardial ischemia, and they tried to compare the efficacy between early PCI and medical therapy alone. However, there is 13 years gap between the two studies, and therefore some big improvements must exist in terms of PCI devices and techniques. The result was initial invasive strategy, including PCI, still failed to reduce the risk of ischemic cardiovascular events or all-cause deaths in the year of 2020. All the innovation of PCI devices, such as newer generation coronary stent and PCI techniques over 13 years, did not make any difference in terms of ischemic CV events or death. Now we have a lesson. When the story is confined to stable coronary artery disease, PCI has no beneficial effect on the cardiovascular heart endpoints. This is the deferred trial published in 2007. The authors compared the efficacy of PCI and medical therapy in patients with functionally insignificant intermediate stenosis, defined as a FFR more than 0.75. In reference group, initial FFR was below 0.75, and both PCI and medical therapy were applied to this group. They concluded that it is safe to defer PCI for an intermediate coronary stenosis based on FFR more than 0.75 in terms of cardiovascular heart endpoints like cardiac death and acute MI after 5 years. This graph raises some interesting issues. PCI to stenosis with FFR more than 0.75 showed no benefits on the CV heart endpoints and even numerically worsened the results. Low pre-PCI FFR itself seemed to be associated with the worst outcomes, and early PCI could not reduce this gap sufficiently. This finding emphasizes the importance of initial atherosclerotic burden on cardiovascular heart endpoints. Now we move to the FAME trial in 2009. Angiography-guided PCI, defined as PCI for all diameter stenosis more than 50%, and FFR-guided PCI, defined as PCI only for stenosis with FFR less than 0.8, were compared. In conclusion, FFR-guided PCI with FFR cutoff less than 0.8 significantly reduced the rate of composite endpoint of death, non-fatal MI, and repeat revascularization, but not the individual outcomes. And the FAME2 trial in 2012, the authors selected patients with functionally significant epicardial stenosis and randomized them into either PCI group or medical therapy alone group. Optimal FFR-guided PCI plus optimal medical therapy to the right patients decreased the need for urgent revascularization, but not cardiovascular heart endpoints. Lessons from the FAME series can be summarized like this. PCI for stable coronary artery disease, if not confined to that with FFR less than 0.8, may increase the rate of MACE. And the purpose of PCI for stenosis with FFR less than 0.8 is to reduce the need for urgent revascularization. Summarizing to this point, any PCI in stable coronary artery disease does not improve the cardiovascular hard endpoints. Low pre-PCI FFR is associated with worse hard endpoints, but PCI cannot solve this problem sufficiently. PCI for stenosis with higher FFR may increase the rate of MACE and should be avoided, and PCI for stenosis with lower FFR decreases the rate of ischemia-driven revascularization. The role of FFR in angiographically intermediate coronary lesion is now well validated, and guidelines strongly recommend the use of FFR to assess the functional significance in these situations. Once again, the role of FFR-guided PCI in stable disease is to reduce the need for urgent revascularization as well as to improve symptom control. Now I'm going to talk about why post-PCI physiological assessment is necessary. Everybody knows that the evidence of myocardial ischemia is a prerequisite for the benefit of coronary revascularization, and because of that, pre-PCI physiological assessment using FFR or non-hyperemic pressure reserve is widely being used in the clinical field. However, PCI to the functionally significant coronary stenosis does not guarantee the complete resolution of all myocardial ischemia. Up to 1/5 of patients have been reported to have residual myocardial ischemia despite angiographically successful PCI, from the bare metal stent era to the drug-eluting stent era. Lower post-PCI FFR is associated with a higher rate of in-stent restenosis and subsequent target vessel revascularization. Post-PCI FFR cutoff value of around 0.9 has been proposed to predict long-term clinical outcomes, which are mainly driven by TVR. A more detailed study revealed that post-PCI FFR as well as total stent length predicts the risk of target vessel failure at 2 years coronary stenting. The 2-year risk could be minimized with post-stent FFR more than 0.9. I mentioned earlier that the purpose of FFR-guided PCI is to minimize the risk of ischemia-driven revascularization. The purpose of post-PCI FFR is to further lower the risk of target vessel failure or subsequent revascularization at 2 years of coronary stenting. However, it should be noted that post-PCI FFR-guided approach cannot improve cardiovascular hard endpoints. Summarizing to this point, despite of the angiographically successful PCI, residual myocardial ischemia is not uncommon in the daily practice, and lower post-PCI FFR is associated with a higher rate of target vessel revascularization. Total stent length and post-PCI FFR are the most important predictors of target vessel revascularization at 2 years. In order to achieve the lowest target vessel revascularization rate, it is important to lower post-stent FFR with as short total stent length as possible, which means that the efficiency of the stent to relieve myocardial ischemia must be maximized. Post-PCI physiology is determined by complex interactions of the stented segment and the residual disease in non-stented segment, subtending myocardial mass, initial atherosclerotic burden, and microvascular function. Other than post-PCI FFR, both percent FFR increase and pre-PCI FFR have been proposed for the independent prognostic factors. More than 50% of percent FFR increase lowered the risk of target vessel failure. Pre-PCI FFR provides prognostic information because it reflects baseline atherosclerotic burden, as the previous deferred trial has shown. Each coronary vessel has subtending myocardial mass, which may determine the amount of flow through the vessel and subsequently the FFR value. In this regard, LAD and non-LAD showed different cutoff value of post-PCI FFR. LAD showed a lower cutoff value, presumably because LAD has bigger subtending myocardial mass. If we apply different cutoff value of post-PCI FFR according to the target vessel, we might optimize clinical outcomes further. Influence of microvascular resistance on FFR has been well validated. Increased microvascular resistance may lead to an increased FFR value, possibly due to the reduction of the coronary flow. Under the high IMR condition, post-PCI FFR may guide to the wrong direction, so we must be careful not to be fooled by the false information. Summarizing to this point, high percent FFR increase, as well as the high post-PCI FFR, is associated with the lower risk of target vessel failure. Pre-PCI FFR also provides additional prognostic information in terms of overall baseline atherosclerotic burden. If we apply different cutoff value in post-PCI FFR according to the target vessel, the rate of target vessel failure may further be decreased. We must consider the microvascular resistance has direct influence on post-PCI FFR value. Then, how can we optimize functional results of PCI? After the angiographically successful PCI is performed, number one, check post-PCI FFR or non-hyperemic pressure reserve. If the value is high, you are done. Medical follow-up. If the value is low, we have to find out how to overcome this situation. First of all, any possible pitfalls should be excluded, such as pressure drift, inadequate hyperemic induction, vasospasm, and catheter damping. These are basics, but are very important. Number two, perform the pressure wire pullback tracing and determines the location where the major pressure step-ups take place. If the major pressure step-up is within the stented segment, there could be any stent under expansion, stent edge dissection, or inadequate stent coverage. Intracoronary imaging such as IVUS or OCT may help, and according to the etiology, additional interventional procedure would be required. If the major pressure step-up occurs in the non-stented segment, if there is another residual focal disease, additional stent implantation would simply solve the problem. If the residual disease is diffusely located in non-stented segment, the efficacy of stent to reduce myocardial ischemia would be decreased. In this case, we must weigh the risk versus benefit of additional PCI. If risk is bigger, medical follow-up is reasonable. If benefit is bigger, additional stent could be considered. Number three, return to number one and repeat post-PCI physiological assessment until the pre-specified goal is finally achieved. This is the backbone of the PCI optimization strategy. Ladies and gentlemen, this is my conclusion. PCI for stenosis with guided by pre-PCI physiological assessment decreases the rate of ischemia-driven revascularization. Low post-PCI FFR non-hyperemic pressure reserve value is also associated with a higher rate of TVR despite angiographically successful PCI. Post-PCI physiology is determined by complex interactions of stented and non-stented segment, subtending myocardial mass and microvascular function. In order to achieve optimized function results of PCI, meticulous pressure wire pullback followed by additional procedure accordingly is the most important steps. Thank you for your attention.